right. There's our information. There's our objectives for those of you that are wanting to get that free 1 hour CE. And again, that will be part of the follow-up email that Jamie will send. We're going to start with a high overview of just dementia in general, understanding that there are over 100 different types. In fact, a lot of numbers now say there's over 130 different types of dementia. Remembering that dementia is just that umbrella term that's used to describe a range of conditions. And then we've got all these different types of diseases that fall under that umbrella. And we're going to look today at what would fall under many times the other. So again, dementia, it is not just memory loss. So many times people will use the word dementia like a synonym for memory loss, and memory loss is just one of about 36 common symptoms to the dementias. Again, over 130 different types of dementia. We tend to see that people have issues with at least two brain functions. Almost always it's memory loss, impaired judgment, impaired language. But that means that a person can have impaired language and impaired judgment and have a dementia diagnosis because they may have one of the types of dementia that presents with no memory loss. Now, that memory loss will come later. It will come with Lewy body, with frontotemporal. Many times they will present with no memory loss, but the memory loss will come. You'll also see the term on here that says reversible dementia. We really don't like that term, reversible dementia, because it makes us think that dementia itself is reversible. There is some memory loss that is reversible. It is memory loss that's caused by things like infection or a vitamin imbalance or a medication interaction. We then treat that and it reverses the memory loss. But we're talking about those irreversible dementias like Alzheimer's disease, frontotemporal dementia, Lewy body dementia. They are permanent brain damage. They are progressive. They're terminal, and there's no cure. And so that is why we do this. We do education. That's how we treat dementia, is we do education. Some of the other areas that are affected by dementia, and I'm multitasking here. Let me let these folks in. Not just with memory, but thinking and reasoning, judgment, language skills, personality, and behavior. Most importantly, please hear, dementia is not a normal part of aging. If you're someone that's part of our programming, you know that all last month was Alzheimer's and Brain Awareness Month, and we were doing a lot of education on how to take care of your brain. Dementia is not contagious, even though if you are around people that have dementia or even a person who has dementia a lot, you can start thinking that you've caught it. You cannot catch it. It is not contagious. But there are things that we can do to take care of our brain to try to either postpone the development of it or to keep those plateaus longer. Let's take a quick look at this picture that we use in a lot of our programs, and it is that brain. We've got a 3-pound brain on the left. We've got a 1-pound brain on the right. This particular brain is somebody with Alzheimer's disease because that's the most common type of dementia. That's why that's the one that we hear of the most often. Today, we're going to be talking about the ones that you may never have heard of some of them, or you may not have known that some of these diseases have the ability to, that they also have dementia related to it, or that it could develop into dementia. But in all of the dementias, we are seeing what's called atrophy of the brain. And atrophy is just simply shrinkage. And you can clearly see it there in this picture. The other thing that you see is those are actual holes that are developed in the brain. So what we say is, how can we expect that person on the right to act and behave and communicate like the person on the left? They can't. It isn't possible. So regardless of what type of dementia our loved one, our client, our resident, our patient has, they are doing the very best that they can do. Please make sure you hear that. They're not giving you a hard time. They're having a hard time. They are going through brain changes that they have no control over. We, on the other side, as the family caregivers, as the professional caregivers, we have the 3-pound brain. We are the ones who accommodate their disease. They can't. They would if they could. So let's look at those signs that somebody in our life might be developing dementia. And again, don't look at this and go, oh my goodness, I forgot an appointment. I must have dementia. Well, you're sitting here telling me that you forgot an appointment. So you remembered that you forgot an appointment. But these are those most common warning signs. And again, I'm going to go through a lot of these really fast so that we can dive into the meat of this. You will get copies of everything. These are the risk factors for dementia. Being over the age of 65, that's the number one thing we've got going for us is age. But it can also develop in people under the age of 65. We see it all the time. I personally, the youngest family that I am working with right now has a loved one who's 28 years old who has early onset Alzheimer's. It is rare, but it can happen for a person to be in their 20s, 30s, 40s and develop some type of dementia. Some of those we're going to look at today. Some of the other risk factors that maybe you didn't know about. Anything that is not good for the heart or the cardiovascular system is not good for the brain. So something like high blood pressure, high cholesterol, diabetes, obesity, smoking is really, really high on that list. We're going to talk about drinking today. Head trauma, we're going to talk about that today. Long-term sleep disturbances, that is sleep apnea. So if a person has untreated sleep apnea, they're at a very high risk for developing vascular dementia. Then we want to make sure we get a proper diagnosis as soon as we possibly can, because it is easy with dementia to try to put it off and put it off because we don't want to deal with it. That grief is already setting in, that denial is already setting in. It can't possibly be. And so we put it off, or we say things like, it must be their hearing, it must be their vision. They must just be getting older. And then we do a program like this and we find out this is not a normal part of aging. This is not because they're getting older. Something's going on if there's actual memory loss. We want to start with a primary care physician so that we can rule out if we've got any of those metabolic type things going on, if we've got an imbalance of some type. We want to rule those out. And then we want to end up with a neurologist, a geriatrician, and we may even see a neuropsych at some point. But there's a team of specialists that we use to get a proper diagnosis. So let's jump into some of the lesser known types of dementia, and we'll start with Parkinson's disease. And this is actually called PDD, Parkinson's disease dementia. Now, I want you to see the latest statistic, and this actually has changed as all of the statistics in healthcare. Every January and every August, they put out new statistics in healthcare. And so 50 to 80% of those living with Parkinson's will eventually experience Parkinson's disease dementia. 50 to 80%. Some of you might remember, I believe it was last year, maybe the year before, Michael J. Fox, who has Parkinson's, I believe in his 31st year of having the disease, said that he would no longer be accepting any acting roles because of his memory loss. So it took that long. Now, he was one of those that it's rare because he developed Parkinson's so early and he has lived with it and lived well for 31, 32 years, but has developed the PDD, Parkinson's disease dementia. So please make sure that you see, will everyone with dementia, with Parkinson's develop dementia? No, but 50 to 80% will. And then 83% of those who have Parkinson's for more than 20 years will develop PDD. And we were just saying he's over 30 years. Parkinson's dementia is fatal, as are all of the dementias. And then let's look at the symptoms of Parkinson's dementia. So we've got the different type of dementias. Some of them there's about 36 common symptoms that all of the dementias share, but we see some more like we may see this a little more in Alzheimer's, this a little more in Lewy body. So what do we see a little more in someone with Parkinson's? That dementia can show up more as disorientation, confusion, that agitation, hallucinations, because that's already a part of Parkinson's disease. So we may see more hallucinations in somebody with PDD, those changes in energy levels where they may also have a lot of paranoid ideas, depression, loss of interest in things. Apathy is really common in somebody with Parkinson's disease dementia. And then I want to show you this because we've got some scans. Let's look at these scans here. So we've got 2 Parkinson's patients with dementia, but they got different levels of plaque. So Parkinson's disease destroys the nerve cells that make dopamine. That's Parkinson's disease. And that is a chemical messenger in the brain that helps control and coordinate muscle movement. Because most people, when they think of Parkinson's or what they know about Parkinson's, is tremor, their gait is off, hallucinations. Those are 3 things that most people know about Parkinson's. So why do some people go on and develop Parkinson's disease dementia? Here's the answer. We don't know. We don't know. Why do some people start to develop this plaque and it becomes Alzheimer's? We don't know. As Parkinson's progresses and it spreads in the brain, it can affect other parts, memory and judgment. So again, let's look back at that statistic again. 50 to 80% of those living with Parkinson's will develop Parkinson's disease dementia. Let's look at this next one. This is drug use and dementia. So let's think when we say drug use, that's really broad. Tobacco, alcohol, cannabis, benzodiazepines, they have negative effects on our brain. Now, we're going to look specifically at some of these. Benzodiazepines are used for things like anxiety. They're used for seizures. They're also used as people are doing alcohol withdrawal. But what we have found is that a lot of people use them and there's like a chronic use of that benzodiazepine. And it's been associated with increased risk of cognitive impairment. But information relating to dementia remains inconclusive. The chronic use of cannabis can impair intellectual disabilities, but data on this topic remains sparse and it's difficult to interpret what data we do have. So, in conclusion of these that are here, there's evidence that some drugs contribute to the cause and development of cognitive impairment, but currently the data doesn't necessarily support where we can't go, okay, research can prove with these. However, let's look at this one. Because some of you, we get asked this question a lot about Benadryl and in things like Tylenol PM. Those have a cumulative effect in the brain. Now, here's a statistic that 54% increase in the likelihood of dementia in those who use Benadryl, Tylenol PM daily, because it has that cumulative effect on the brain. It's changing the makeup of the brain. So again, before we all panic, we've got it in bold print here. Benadryl and similar antihistamines, cold or flu drugs, and Tylenol PM or other over-the-counter sleep aids did not show any relationship to cognitive impairment if used for 3 months or less. And this was studied. But if used for over 3 years or at higher doses, there's significant risk of impairment. And I hear from people all the time, I've been using Benadryl for years. I've been using Tylenol PM for years. We've got to find another thing to do. We've got to look at melatonin. We've got to look at sleep hygiene. But some of the other things, if you look at that last bullet point, the active ingredient in Benadryl, that's an older antihistamine, and there are newer drugs on the market that can replace it if it's necessary. Let's look at alcohol use. And I'm going to show you a scan of a brain of somebody who has alcohol-induced dementia. Alcohol abuse is actually very common in people over the age of 65. 60% report drinking regularly, and 5 to 10% report binge drinking. So then we've got to think, that's how people reported. Were they honest when they reported? So what is binge drinking? It's 5 or more alcoholic drinks for males or 4 or more for females at the same time or within a couple of hours of each other on at least one day in the past month. Heavy alcohol use is binge drinking on 5 or more days in the past month. So let's look at the brain. This is someone who's 43 years old. Some of you may have been told when you were a kid not to drink, not to do drugs. If you grew up in the 80s, we even had commercials that talked about, here's your brain on drugs, and they put the eggs in the frying pan. That was true. This is a 43-year-old on the right with alcoholism. It really does kill brain cells, and it causes severe damage to the brain. It shrinks parts of the brain. If you look at that last bullet point, some experts say that people with alcoholism have a smaller hippocampus, and the hippocampus is responsible for learning and memory. Some of the things that we see and how it shows up in people with alcohol-induced dementia: blurry vision, slurred speech, poor judgment, poor decision-making, and memory loss. This is preventable. This almost always starts before the age of 65. And it seems like the younger we are, the more we think, well, it couldn't happen to me, or it couldn't happen to our loved one. But let's just go back, because this is a powerful image here. That didn't happen overnight. That happened over a long period of time, and that person is 43 years old. So I've had people ask, is it reversible if they stop drinking? If they stop drinking, do you see improvement? You sure do. But does that brain go back to looking like that brain on the left? It does not, because it can't. That damage is done. Those brain cells have died. So what is happening when we're drinking heavily? It can result in high blood pressure. It can result in an irregular heart rate. It can result in stroke. And all of those point straight at vascular dementia, which is one of the most common. So we will get people who will have a diagnosis of what's called a mixed dementia, where they have more than one. They may have alcohol-induced dementia and vascular dementia. Another thing that's linked to heavy drinking is cigarette smoking, depression, addiction, which also leads to dementia. We're going to look at depression. Untreated depression. Well, a lot of people treat their depression with alcohol. They're self-medicating. So you may be looking at that and thinking, oh, but I'm not an alcoholic. My loved one's not an alcoholic. They don't fall under that binge drinking. But are you exceeding? Drinking more than the recommended limit increases your risk. So the limit is 14 drinks a week. So that's about 2 drinks a day. Are you having more than 2 drinks a day? Because that's harmful. And it's things that we've got to look in the mirror about Because it's very, very easy to finish that bottle of wine. I hear it too often from caregivers. I used to have a glass, now I finish the bottle. That's raising our limits. So we talked just a little bit ago, those memory problems, language impairment, inability to perform complex motor tasks, high risk for falls, and people who have alcohol-related dementia. And then dementia, alcohol is also damaging the heart and the liver. There can be nerve damage in the arms and the legs, which results in neuropathy. Many times in people who have alcohol-related dementia, they have, with that neuropathy, the sensation in their extremities. They've got problems with that. And then let's look at this, and this has a particular name, Wernicke-Korsakoff syndrome. So alcohol-related dementia is a broad term, and under that broad term, there's some specifics. Wernicke-Korsakoff syndrome is more specific, and this is from a thiamine deficiency. It's the most prevalent form of alcohol-related dementia, and it's a combination of two. It is Wernicke's encephalopathy and it's Korsakoff's dementia. Someone may develop one or the other, but very often they're together. That's why you'll see it as Wernicke-Korsakoff syndrome. And it's that thiamine or B1 deficiency caused from alcohol abuse, because alcohol prevents the body from properly processing that vitamin. Let's go to traumatic brain injury. Traumatic brain injury. It is a blow or a jolt to the head or to the body. Now, not all blows or jolt to the head or to the body results in a TBI, but repetitive blows or jolts is a major risk for TBI and CTE, which we're also going to look at. Traumatic brain injuries can range from mild to severe. So a mild injury can affect brain cells temporarily. It's like a brief change in mental status. But a severe injury can bruise, tear the tissues, cause a brain bleed. Someone who has an extended period of unconsciousness or has memory loss or other physical damage to the brain is at that high risk of what's called a TBI. TBIs, traumatic brain impairment, can show up as memory issues, movement issues, sensation, like we talked about with the alcohol, where maybe some tingling in the extremities, and emotional functioning. So let's look at this graphic here and what happens in a concussion. So if you look at the picture, we have the blow to the head, the brain bounces off of the skull, and it rotates, it moves. Our brain is very protected with our skull. And then it's also kind of floating here. It's 3 pounds. If we had it here, if we had that 3-pound brain, it'd almost be like trying to hold some Jello. But it can be bruised, it can bleed, it can be damaged, and the tissues can tear. So what does that look like when somebody has a traumatic brain injury? And it is a wide range, depending on where is the blow to the head and how severe is it. So let's look at the physical and the sensory symptoms, and we've got it divided into mild and severe. Mild can be things like a headache, nausea, vomiting, dizziness, ringing in the ears, things like that. And again, you are going to get copies of these slides. I know people are going, oh my gosh, I can't write all that down. You're going to get copies. Severe, any of those mild symptoms that persist or they get worse, losing consciousness, that makes it severe. The pupil dilating, weakness and numbness in the fingers and toes, not able to wake up. Let's look at the cognitive and the behavioral symptoms. So mild, mood changes, mood swings, difficulty sleeping, severe slurred speech, coma, agitation that can show up as combativeness, or any other type of unusual behavior, not able to recognize people or places. So, what causes TBI or traumatic brain injury? The number one risk factor is falls, uh, car accidents, violence, sports injuries, which is where most of your minds probably went, but not everybody plays sports and still ends up with TBI, explosive blast or combat related injuries. Over the past 30 years, they've been studying traumatic brain injuries. And what they've discovered is that people who've had traumatic brain injuries, even one, and of course, the more a person has, the higher the risk, are at a higher risk of developing Alzheimer's disease or other dementias many years after the original head injury. And then repeated TBIs are associated with CTEs, which we're going to look at next. And people who experience TBI in early to midlife, listen to this, early to midlife, that's when we're playing those sports, that's when we're doing those things, are 2 to 4 times more likely to develop dementia later in life. And that risk is higher the more traumatic brain injuries they've had. That is why we see so many professional athletes, college athletes, who then end, people will think football, but I also want you to think about things like soccer, things like rodeo. We're in Texas, so rodeo. All of the sports where you could have a traumatic brain injury. This is not just football. So that leads right into CTE. It is rare. It is not well understood. It has a complex relationship to those head traumas. Some people will even call it like a post-concussion syndrome. So let's look a little closer at CTE. It is repeated head trauma, and it's associated with the development of dementia. CTE is not related to the immediate consequences of a late life episode of head trauma. These are almost always things that have occurred earlier in life, repeated head traumas. And then let's look at that fourth bullet point. CTE has been found in the brains of people who played football and other contact sports, including, here's another big one, boxing. It may also occur in military personnel who were exposed to explosive blast. Some signs and symptoms of CTE are thought to include difficulties with thinking, so cognition, physical problems, emotions, and other behaviors. It's thought that these developed years to decades after the head trauma occurs. That is why the family may be going, but that would, yes, they had that happen, but that was back in the 1960s. What do you mean something's showing up now? That's exactly what this is talking about. Can it show up decades later? Absolutely, it can. It can show up. CTE cannot be made as a diagnosis during life, except in those rare individuals with high risk exposures. Researchers do not yet know the frequency of CTE in the population, and they don't fully understand the causes. There is no cure, but let's look at some scans here. There are not specific symptoms that make us go, well, that's CTE. But they usually have a pretty good idea because they know about all of the TBIs, the traumatic brain injuries that have happened. But let's look here at this picture. And they've got the control on the left and Alzheimer's disease on the right and CTE in the middle. Look at the changes. And look at that second bullet point. These symptoms don't usually show up right after the head injury. It's years later, decades later. And some of the things that families will say, loved ones will say, is how they started to change. Their personality started to change. Emotionally, they weren't stable. They were having a hard time carrying out tasks. They may develop substance abuse because they're self-medicating. It is common for them to have suicidal thoughts or behaviors. Now, how do we get it diagnosed? There is not a test for this. It can be suspected, like we said. So they will do medical history, mental status testing, neurological exams. CTE does involve that tau protein, which is the same one that we see in Alzheimer's disease, but the buildup is different. The hope is that advances in brain imaging is going to help with diagnosis for this. There's no medications to treat it. It's just symptom management like all of the dementias. So there's much, much more research needed with TBIs and CTEs. Let's move on to our next one, which is going to be normal pressure hydrocephalus. Normal pressure hydrocephalus. This is an abnormal buildup of that cerebrospinal fluid in the veins, the brain's ventricles and cavities. So we all have the cerebrospinal fluid. It washes over our brain. At nighttime, it really does the work by we call it taking out the trash. While we're sleeping and resting, when we're sleeping well, that's why it's important that we sleep well, that cerebrospinal fluid is washing over the brain and it's getting rid of the toxins. And yes, somebody was asking about the slides. You're going to be sent the slides and a copy of this, plus it will be up on our YouTube page. So what makes it happen? What happens is those ventricles start to enlarge in the brain and it puts pressure on the brain. It can disrupt and damage brain tissue and cause all types of impairment. It can occur at any age. It's most common in people over the age of 65, and about 5% of the time we will see it develop into dementia. Because some of the causes: a ruptured aneurysm, a head trauma, a tumor, an infection like meningitis, complications of a surgery, and then of course there's going to be those unknown causes. But let's look at a brain that has this normal pressure hydrocephalus. Normal brain on the left, and there's NPH on the right. So what do we tend to see? It's a progressive decline in cognitive impairment like all of the other dementias. Now, again, are we saying that everybody's going to develop dementia? No, you saw it was just 5% of people who have NPH. Does it go on to then become dementia? They can start to have issues with bladder control, general slowing down of their movement. Many times those cases go unrecognized and they don't get diagnosed properly, or they get misdiagnosed. As do many of the dementias, they'll get misdiagnosed. There are tests that they do. They're going to start with those brain scans, the MRI, the CAT scan. They may do the spinal tap, a lumbar catheter, intracranial pressure monitoring, the neuropsych testing to see if it is affecting cognition. If it is not treated, now there are treatments for NPH, we're going to look at it next, it will get worse and it will become fatal. So early diagnosis is what's key here. But this is one of the few that can be controlled, and NPH in many cases can be reversed. Got to catch it early, and then we've got to treat it. And what they do is they go in and they surgically put in a shunt to drain off that excess cerebrospinal fluid. And the shunt typically goes to the abdomen, where it's absorbed as a normal part of the circulatory process. And what happens with that, it allows the brain ventricles to return to their normal size. Success of treatment varies from person to person. Some trials suggest improvement of symptoms range between 50 to 90% of those that have the shunt put in. And again, we said only 5% of those go on to develop dementia. Let's next look at Huntington's disease, or sometimes it is called Huntington's chorea. The word chorea is Latin for the term dance, and it is because of the movements that the folks develop who have Huntington's. This is rare. It is an inherited disease. If someone has it, there's a 50-50 chance that their children are going to develop it. The rate of progression is very different. It can be from 10 to 30 years, and it can be seen in people in their 30s, 40s, and 50s. It can develop in people in their 20s. And what we tend to see is that the earlier a person starts to develop the symptoms, the faster that it moves. It is a gene mutation, is what it is. We have on there again that each child of a parent with Huntington's has a 50-50 chance of inheriting the gene. A child who does not inherit the gene will not develop the disease and generally cannot pass it to subsequent generations. A person who inherits the Huntington's gene will eventually develop the disease. Huntington's is generally diagnosed based on genetic testing, medical history, brain imaging, and neurological and laboratory tests. Now, we use that word chorea, and again, I said that was Latin for the word dance, because chorea is a medical condition and it is a movement disorder where the person actually, the way that the body, it's like the body sways back and forth. It's very different from Parkinson's or some of the other types of movement disorders that we see, because there's an inability to control this movement. Sometimes it's jerking, sometimes it's twisting. Some of the other symptoms that we see is a lack of awareness of their own symptoms or behaviors. And I know I had a woman who had Huntington's who was standing at my desk, and as she was moving, as she was swaying, she was knocking things off of my desk, and she did not realize that she was the one knocking things off of my desk. She was unaware of the connection to her body and what was happening. They can also get stuck on a thought. It's very common that they'll get stuck on a thought, and it's very, very difficult to distract them from that thought. They can develop what looks like OCD or obsessive compulsive disorder. Some of the other symptoms that we have with Huntington's: inappropriate behaviors, difficulty with complex tasks, lots of personality changes, and I want to show you a brain of somebody who has Huntington's disease. So this is that MRI. We've got the normal brain there on the right. We've got the Huntington's on the left, and you can definitely see the changes there. Also with Huntington comes a lot of changes with psychiatric disorders. So depression is very common, frequent thoughts of death, suicidal ideations is very common in people with Huntington's. And then these are the stages, because it goes through like all of the dementias. There's like an early, mid, and late stage. And these are what the stages looks like with Huntington's. Again, you are going to be getting all of these, so do not panic thinking that you're needing to get all of this written down. There's no treatment for Huntington's. What we do is we treat the symptoms. And there are medications that help with that movement, with the sway, with the chorea. There are also medications for depression and anxiety. And then there's physical therapy, occupational therapy, and speech therapy, which we recommend for all of the dementias. Our loved ones, our clients, residents, patients are going to go in and out of all of the therapies. And sometimes people will say, but there's no cure. Right. It is not curative, but it's comfort. It's comfort measures, because the entire point is quality of life. Quality of life. And if going in and out of physical therapy, occupational therapy, and speech therapy can bring quality of life, then that's what we're going to do. So let's look at malnutrition and vitamin deficiency. When a person's diet doesn't provide enough nutrients or the right balance of nutrients for optimal health. So it can then lead to dementia. We've talked about obesity, but it can also be from malnutrition. So let's look at the cause and the risk factors. A reduced food intake due to mental health issues or a poor appetite. Depression, fad diets, limited income, alcoholism, trouble swallowing or chewing, other eating disorders such as bulimia or anorexia. One of the things that we often don't think about is malnutrition and aging and how that affects the body, the changes with the muscles and the bones and the healing and the immune system, the ability to fight off infections, be able to recover. to be able to heal, to have those reserves. But there's also such a thing as malnourishment for our organs, including the brain. So nutrient deficiencies can cause a loss of neurons that can lead to cognitive impairment. So what does that look like? Loss of speech, poor coordination, memory loss, lack of concentration, disorganization, and apathy. So what can we do about this for treatment? We've got to adjust our diet and make those smart food choices. We've been talking a lot about the MIND diet, M-I-N-D, the MIND diet. Please look that up. We've got an entire program about diet and exercise. The MIND diet is 10 do's and 5 not so much. It doesn't even say don't, it's just 5 not so much. Look at that second one, hydration, water. It's an important nutrient for our body. When somebody is dehydrated, and you may have been this way before, if you are really, really dehydrated, you're confused. I'm not thinking clearly. Exercise, pushing oxygenated blood up to the brain, and we need to be doing this every day. In January, when those new healthcare statistics came out, what had switched, we've always said diet and exercise, and it's flipped now. It says exercise and diet, that exercise is even more important than diet, because what's happening with exercise, we're improving our strength, it can increase our appetite so that we eat healthy, we're building muscle, it helps with balance, it helps with stamina, which means we've got more reserves, and we're pushing oxygenated blood up to our brain. Doesn't mean you've got to go out and jog. There are all types of things you can do that is movement to push oxygenated blood to our brain. And then taking care of our mouth and our teeth, because poor oral health can lead to gum disease, which can also limit the way that we eat. Next, let's look at ALS. ALS in Greek, the words mean no muscle nourishment. When a muscle has no nourishment, it atrophies and it wastes away. And so when neurons die, the brain's ability to control the muscle movement is lost. People eventually with ALS lose the ability to walk, speak, eat, move, and eventually breathe. There's 2 types of ALS. There is sporadic, which is the most common. This is 90 to 95% of all cases. And then there is a lesser known, we don't see it near as often, and it's a familial type of ALS, and we see it in 5 to 10% of all. In these families, there's a 50% chance that each offspring will inherit the gene mutation, just like with Huntington's. So let's look at the symptoms of ALS. Now, it's different from person to person. One of the things that it's common for somebody, the very first thing they notice is the way they hold things, or they're picking something up. They may trip, or they're dropping things more often. They've got an abnormal fatigue in their arms and legs, or their speech is even a little bit slurred. Now, ALS has a gradual onset. It does not just come on overnight. The senses of sight, touch, hearing, taste, and smell are usually not effective, since the disease attaches to different motor neurons, and the bladder is typically not affected either. But muscle cramps or twitches can have uncontrollable laughing or crying. So how to get diagnosed? ALS is often diagnosed because they rule out other diseases. There are tests that they can do where it is a nerve conduction test, blood and urine test, spinal tap, x-rays, MRIs, nerve and muscle biopsies, and then a neurological test. We always, always, always with ALS recommend that someone get a second opinion. It has been found that military veterans do tend to develop ALS more often. ALS impacts veterans regardless of the branch of service. And what's interesting is that it affects those that were both during peacetime and wartime. The connection has not been made yet. There's some ideas. A lot of people will think of ALS, and the first thing that comes to mind is Lou Gehrig, because it is also called Lou Gehrig's disease. And this particular picture is a very famous photograph. This was in 1939, and the title of this picture is "The Day Lou Gehrig Took Himself Out of the Game." He had started to panic at how his body was failing him, and he didn't understand what was happening. What had become very easy for him was becoming very difficult. He played 2,122 consecutive games of baseball. He was diagnosed at the Mayo Clinic on his 36th birthday, and he died 2 years later. Most people are diagnosed between the ages of 40 and 70. That average is 55. It can happen in people in their 20s and 30s. It's 20% more common in men than in women. And again, the onset of ALS often involves muscle weakness or stiffness. That's how many people will know that something's not quite right. Average life expectancy is 3 years. 20% live about 5, 10% can live 10, 5% live 20 or longer, but average is about 3. There are 4 approved drugs from the US FDA to treat ALS. It has been shown that people who get in support groups, that really helps with their quality of life. And 50% of all ALS patients demonstrate mild to moderate cognitive and or behavioral impairments that departs from their baseline. Now, here's the statistic on dementia. 20% of ALS patients meet the criteria for dementia. So 50% is going to have some mild changes. Maybe it'll look more like mild cognitive impairment, or it's not interfering with day to day, but 20% will go on to develop full-blown dementia. Now, what's interesting, when you go to als.org, which is a really good resource, als.org acknowledges that physicians rarely discuss the possibility of dementia with their patients. Physicians rarely discuss dementia with their patients. Most of us that are on this call know that. That's one of the reasons that we do what we do. Educate. People with ALS many times will go on to develop what's called FTD, or frontotemporal lobe dementia. It's caused from, or frontal lobe dementia. It's caused from destruction of cells in the frontal lobe of the brain. It changes personalities, it changes behaviors, apathy, lack of emotion, reduced spontaneity, memory loss, loss of speech. Probably the person that you're going to recognize is Stephen Hawking. He lived for 55 years after his diagnosis. Now, some of the things that we've got to remember when we talk about living 55 years with this diagnosis, he had access to exclusive nursing care, experimental type treatments, medical care, and he was diagnosed at 21 years old. Now, here's an interesting fact. The younger that a person is diagnosed, they tend to live longer. Where with other dementias, it's opposite. The younger they're diagnosed, they tend to have a shorter life expectancy. With ALS, the younger a person is diagnosed, they tend to have that longer life expectancy. Now, ALS, they are at a very high risk of choking, developing pneumonia, digestive blockages, and infections. Most people with ALS, if they live long enough, they require a ventilator. If they choose to go that route, many patients will opt out of that and allow the disease to take its course. Next, let's look at multiple sclerosis. And many people don't realize that MS was moved under the dementia umbrella several years ago. Now, again, that does not mean that every person who has MS is going to develop dementia. We're going to look at the statistics of that. But first, let's look at what is MS. It is a disease of the central nervous system, and what happens is it disrupts the flow of information from the brain, between the brain and the body. So anytime we've got something going on with the brain, we've got that possibility of dementia. The cause, you hear this over and over, unknown. Scientists believe it could be a combination of environmental and genetic factors with abnormalities in the immune system, but they don't know. The progression, the severity, the specific symptoms, it's just like with all of the dementias. If you've seen one person with MS, you've seen one person with MS, you've seen one person with dementia, you've seen one person with dementia. Most of the time, people are diagnosed between the ages of 20 and 50. It's an abnormal response of the immune system, and it's directed at the central nervous system, which includes the brain, the spinal cord, and the optic nerves. The immune system causes inflammation, and damage to areas of the central nervous system produce neurological symptoms, and it produces scar tissue. So we're going to look at a brain in just a minute of MS. There's 4 types and stages of MS. There is what's called clinically isolated syndrome, relapsing remitting MS, secondary progressive MS, and primary progressive MS. And so you can see there the statistics that go along with each one. And again, I have got to start going faster so that we don't run out of time. Again, you're getting these slides. There's the symptoms, the most common symptoms that we see with MS. Here's the diagnosis. There is not just one test. They're going to rule out other conditions. The ones that they tend to rule out are Lyme disease, syphilis, HIV, brain tumors, a copper deficiency, a vitamin B12 deficiency. And again, we always recommend a second opinion. To get a diagnosis of MS, there must be evidence of damage in at least 2 separate areas of the central nervous system, and find evidence that the damage occurred at different times, and rule out all other possible diagnoses. Who gets MS? Anyone can develop MS. It's 2 to 3 times more common in women. They tend to have low vitamin D. Cigarette smokers are at a high risk. It's most common in Caucasians, and it's usually, again, between 20 and 50 years old. Some other facts: it is a chronic condition. There is no cure, but the disease itself is not fatal. Most symptoms can be managed with medications and lifestyle changes. It can be really difficult to diagnose. Again, that's why we often say, let's make sure that we get a second opinion. Treatment: there are more than a dozen approved therapies. 9 are injectable, 10 are oral, 4 are infused, and they are used to treat symptoms. There are a lot of celebrities who have come forward and talk about their MS. Probably Christina Applegate there in the top right is the one that is the most vocal. She talks a lot. She goes on shows. She makes sure that everybody is aware, and she is one who is normalizing this. But some of these other folks you might not recognize. Terry Garr is on there. Jack Osborne's on there. There's Montel Williams is on there, but a lot of people have come out and talked about their MS. So let's talk about MS and dementia. 22% of those with MS will go on to develop dementia. 22% of those with MS will go on to develop dementia, because there are lesions that are on the brain. And what happens to those lesions is that the signals traveling through the nervous systems get lost, or they get destroyed. And if they start to get destroyed, we start to have memory deficits. Cognitive impairment and MS. Let me get over here to the picture because I want you to see the lesions on a brain of somebody who has MS. So this would be an abnormal MRI. You can see there, these are lesions. These are approximately 2.5 inches in diameter. So that was a really fast tour over lesser known types of dementia. Let me get over here to the questions really fast. Jim, yes, contact me on my email. So email was on that last slide. Does the type of alcohol consumed determine the level of brain cells lost, let's say wine as opposed to liquor? I have not seen anything like that, because wine, a lot of folks will say, oh, but it's wine. Wine is good for you. It is good for you. 5 ounces at a time. 5 ounces is what's considered. And I always, with love and compassion, say, I've heard, you can see my Stanley, that an entire bottle will fit in one of these Stanleys, but that's just one drink. Well, that's a whole lot more than 5 ounces though. So we do need to be careful with all of it. So an alcoholic, my mom's had it, it's very heavy. Xanax user, yes, 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 yes. So there's a time and a place for an anti-anxiety medication. Absolutely, I get it. I understand it. I have used them. Those are short term. Those are short term. Something that an antidepressant, we're not going to get this. An anti-anxiety, yes, there's a difference. There's a difference. So we want to use those anti-anxiety short term, please. Let's see. Thank you, thank you, thank you for all the nice things. Thank you so much. We are right at time. Be looking for the slides and the presentation. Jamie will send that out later today. I thought she was going to be hopping on. I forgot she had another program. That's why I'm doing this month. And be looking for that. Plus, it'll be up on our YouTube probably within 48 hours. Glad all of you were here. Thank you so much. Be looking for an email from Jamie with the slides.